So I'm presenting an interesting case from Atlanta, Georgia, of a patient that we treated in our burn unit who had thrombotic cutaneous gangrene secondary to vasculopathy in a patient with ulcerative colitis. So a little bit of background. In general, patients with inflammatory bowel disease are about 3 times more hypercoagulable than the general population. Thrombotic cutaneous gangrene is diagnosed in about 6% of IBD patients, but found in about 40% of postmortem examinations. It is a multifactorial etiology, and it can be due to several things: underlying endothelial damage, altered levels of coagulation enzymes, increased anticoagulation antibodies, as well as side effects of various therapies. What you often see is factors 5, 7, 8, and 10, fibrinogen levels, von Willebrand factor, platelets, and cryoglobulins are typically elevated. Antithrombin 3, protein C and S, are typically decreased, and this is often due to the underlying damage in the intestines leading to loss of proteins. Treatment can include anticoagulation and systemic IBD therapy, but this has not been standardized. So for a patient was a 51-year-old African-American female with poorly controlled ulcerative colitis, even on biologics. She initially presented to an outside facility with right flank bruising, nausea, dizziness, and some weight loss. CT scan showed pancolitis. She had no prior history of any anticoagulation use or thrombolysis, and she was discharged at that time to antibiotics and some topical ointment. She represented at that outside facility and started having some blistering of her left flank wound, toe bruising, and left periareolar erythema. At that time, she was given some steroids, vitamin K, and a hypercoagulable workup was started. As her skin lesions progressed and became more gangrenous and tender, she was transferred to our facility in the burn unit, actually, for a more multidisciplinary approach where we have burn surgeons, general surgeons, and dermatologists as well. As you can see on the right of the screen, examples of her biopsy results, as well as her colonoscopy showing this pancolitis. And then if we look down in the left lower hand corner, we can see sort of the timeline of the treatment that we offered for our patient. So when she started, we started her pretty soon on a heparin drip, and all of her lesions, except for her left flank, showed improvement. She was also started on some IV steroids as well. Initially, her left flank here began, even on the anticoagulation, began infarcted, and we made the decision to take her to the operating room for debridement and eventually placed the wound back. Throughout her hospital course, she was transitioned to oral anticoagulation and oral IBD medication, and also received a dose of biologics. After discharge, she was seen in our clinic. Her wound vac was removed, and it showed great healing. Almost, she did not need a skin graft or any other intervention at that time. However, she has since represented to the hospital in another acute flare, showing another failure of biologics. There are a few cases in the literature that have similar presentations, IBD patients with various sorts of lesions, and they've undergone various therapies as well. Some have been treated with anticoagulation, some with IBD treatment, and some with both. What's interesting is that various combinations of these either show resolution, with 1, 2, or both of the modalities. And some who have gotten all 3 of the modalities actually show progression and need, amputations, skin grafts, and so forth. So our treatment decision in our patient was driven a lot by her symptoms. And, it brings up a lot of interesting questions of why do some IBD patients develop these lesions? And also, what is the ideal treatment and timing for use of, let's say, anticoagulation versus IBD treatment that we can prevent further progression of these lesions? Wanted to thank everyone for their time, and